All right. Am I on the Zoom now? Is that how it works? All right, excellent. I have the pleasure of introducing our Grand Round speaker today. Let me just pull my notes. So hello, everyone. Welcome to Grand Rounds and our annual Caldwell Visiting Professorship. I think for those of you who don't know Jim Caldwell, he has been on our faculty for many years at the VA and at Montlake in our nuclear laboratory, even including a stint as chief of cardiology. He's really been a fantastic mentor for fellows over the years, as well as faculty, mentoring current faculty members, even Lori Soini and Kelly Branch. And I remain very grateful that he is so supportive of our fellowship program. I'm delighted to introduce Annabelle as our 8th Caldwell professor. The intent of this professorship is really fellow-driven activity focused on networking and fellow education, and that together the chiefs kind of worked through options and selected Annabelle as this year's candidate. And to organize educational sessions and things like that. Yesterday, Annabelle met with the fellows one-on-one with senior faculty. She taught didactics, and we actually really heard some fantastic case presentations by Kate Kahn, Cooper Kersey, and Alex Hoffman. Annabelle is the Madeline and James McMullen Carl Ebile. Wow, lots of names.
I know. Got rid of us.
Endowed Chair for Excellence in Clinical Cardiology at Rush University. She's really been a stalwart in the Midwest, having gone to medical school at the University of Chicago and then to Northwestern University for her residency and fellowship, and then moving to Rush University for her faculty position, where she was one of the first, or was the first EP physician at Rush University. During her time there, she really founded and developed her niche in women and cardiovascular disease and started the Rush Heart Center over 20 years ago. I think it's closer to 25 years now, and has been a dedicated advocate in building community outreach through groups such as Women Heart and advancing scholarship in women and cardiovascular disease with the AHA and the ACC. More recently, she's taken really key leadership educational roles for Rush as the Vice Chief of Academic Affairs for the department and as the Illinois ACC Governor. It was really fascinating yesterday to hear her academic trajectory and course. I think it was very inspiring for the fellows to hear about. And with her extensive work in community and heart health, she's been able to really forge, I thought was fantastic to hear about her relationships and develop philanthropy for the Rush Heart Center. And then we also talked a lot about our shared identity as Filipina cardiologists and wondered how many of us are out there in academic practice. I think we're actually going to try and get together a group at ACC, and it might just be you and me.
Wow.
I don't know.
We're going to have fun. We're going to have a lot.
You never know. The other thing you may not know about her, she's a fierce stock junkie, which I did not know that. And so she knows ups and downs and when to buy and sell. And it was really great to hear her advice also to fellows about just thinking about investments and learning about, things that are still life important, but not necessarily in the hospital. Her timely discussions regarding promotion criteria, engagement, enthusiasm for your niche for fellows and networking in your institution within the community across programs was really sage advice. And I really look forward to hearing her grand rounds on women and heart disease. So Annabelle Volgman, thank you.
Thank you. Thank you so much, Rose. It's my
I'm sorry, I forgot.
Present to you the
So just for the
for the Zoom.
wow.
We
Wonderful.
want to present to
This
you
is
our
beautiful.
this year's Caldwell Professorship plaque with your name on it. How about that?
No, thank you.
Thank you so much.
Santos.
Hey, what? I'm getting it.
Thank you, Eugene.
It's been a total honor having you here, so thank you very much.
Oh, thank you so much. I have this. We can probably turn that off. Thank you so much. So Rose, thank you for that wonderful introduction. It's been such a pleasure being driven around and picked up and dropped off by several of the fellows and the attendings. So it's been such a pleasure meeting everybody here at UW. I didn't used to call it that, but now I know how to say it. So I didn't realize Rose was going to tell my financial secrets. Well, as you know, women are still paid 80% of what men are paid. So we have to do something to compensate for that. And I learned a trick, which is put your money in the stock market. But you have to be careful. I'm not giving any advice to anybody, lest I be accused that I'm making you lose some money in the stock market, but it is a good investment. Anyway, I'm going to start off with what I have learned over the last 20 years, more than 20 years since I started the Rush Heart Center for Women, actually with Martha Gulati, which was your Caldwell professor last year. So we've been doing this together, although she left Rush and went to different places. I've been at Rush and taken care of a lot of patients. I've probably seen thousands of patients over the last 33 years that I've been at Rush. And as Rose said, I'm an electrophysiologist. I took care of a lot of people with arrhythmias, a lot of women with palpitations. And so I'm going to forward my slide if this can move. Okay. It's not moving. Bryce. So my next slide is my disclosures, which I include Apple stock in there because I do talk about how I diagnose palpitations in women and men. And Apple has an Apple Watch that can detect arrhythmias. There you go. So let me
Oh, yeah,
see.
this thing works.
Okay, good. Thank you. Yeah, thank you, Bryce. You're a fixer-upper. So these are my disclosures. I do have some NIH grants, not because I applied for them, but because I collaborate with my nurse practitioners and my nurses who have PhDs, and they do a lot of lifestyle work, lifestyle activities to help decrease dementia or cardiovascular disease. So those are my NIH grants. I do have Novartis also as a funder of my clinical research in some. So I was going to say this is one of the complaints that my patients come to the Rush Heart Center for Women because I'm an electrophysiologist. A lot of women are referred to me because of palpitations. So I've done a lot of research on this. I've collaborated with a lot of my colleagues to help women with palpitations. So I'm going to share with you my research results from over the years that I've learned from women. So this is the #1 cause of palpitations in women. So for the women out there, would you agree that this can cause palpitations? I'm sorry about the man. Usually I have a lot more women in the audience and they love this slide. The men say, okay, great, thanks. But I love making the slide. I get to go and Google and see beautiful faces. I should make one for men, but it's okay. So I'm going to tell you this history of the Rush Heart Center for Women. This is a T-bar or an I-bar, which one was the first bar that was used to create the Rush Tower that you saw, the butterfly building. And so we started that as old as that tower is. Probably this was even later, but it was a great way to showcase my colleagues. Martha is not included here, but Lynn Brown to my right there is a nurse practitioner. She has a PhD. We had an Eastern medicine doctor who was at Rush, and she wanted to join us. She does hypnosis, she does acupuncture, because a lot of the women who come to us also are into that. And so I wanted to have somebody who knew that field of medicine that they wanted to do. And so I thought it would be good to include somebody from Rush that has the credentials to do that with my women. We also have a cardiocognitive neurologist. So this is fast forward to my new colleagues who are now at Rush. We have 12 female cardiologists. The Dr. Agarwal is, let me see if I could use the pointer. Dr. Agarwal is our cardiocognitive neurologist. And she is a dementia neurologist, but she was also very wanted to understand why women have more dementia than men. So we partnered together. I used to refer my patients to her memory clinic, but my patients would never show up because they would either forget or they would not want to be seen in the memory clinic. But anyway, another colleague is a cardio genetics person. So she's been very busy with all of our aortopathies and cardiomyopathies. So we have a lot of different fields that take care of all these women, and that's what we have been doing. And we were just honored at the end of February for the 20th anniversary of the Go Red for Women, which I've been involved with for the last 20 years, more than 20 years, since the AHA approached me more than 20 years ago to increase the awareness about heart disease in women. So why did the AHA approach me back then? I think I showed this slide to the fellows yesterday, that in 1979, the blue line is mortality in men, cardiovascular mortality in men, and the red line is the cardiovascular mortality in women. And as you can see, in 1979, there were more men dying of heart disease, about 30,000 more. But we saw a change in that when the women were given hormone replacement therapy, because the Nurses' Health Study, which was an observational study, showed that women who took hormone replacement therapy was associated with less cardiovascular events. So they made the conclusion that hormone replacement therapy was good for heart disease. Unfortunately, that didn't prove to be the case, because as you can see, it increased cardiovascular mortality. HRT decreases LDL cholesterol, but it also increases blood pressure, triglycerides, lowers LDL, so it was negative for that. So the WHI study, which is the Women's Health Initiative, which is multi-billion-dollar NIH study, sponsored by Bernadine Healy, who was the first NIH woman director, finally showed some outcomes. Unfortunately, that group of women in the WHI showed that women who were over 60, the average age of those women were over 60. So they were more than 10 years from their menopause. And when they were given hormone replacement therapy, they had an increased risk of strokes, heart attacks, and deaths. So we stopped giving. So by then, 2000, the year 2000, there were 70,000 more women dying of heart disease than men. And this was around the time that the American Heart Association and the NIH said, okay, we need to do something about this. They started the Red Dress campaign. They did a lot of work to study women and heart disease and what the symptoms are. We stopped giving hormone replacement therapy. We started using cardiac troponins. I was telling the fellows yesterday how amazing cardiac troponins was to detect the small myocardial infarctions that women tended to have compared to men. And we started heart centers for women all over the country. And as a result of that, we were so proud to see that there was a marked decline just after doing those over the next 10 years. So between 2000 and 2010, we saw this marked decline in cardiovascular mortality in women. Unfortunately, as you know, COVID did not help cardiovascular mortality in men and women. There was a marked increase from cardiovascular mortality as a result of people not coming to the ER with their heart attacks and strokes. And so we saw an increase in cardiovascular mortality in both men and women. But even before COVID, we were starting to see an increase in mortality in men. I talked to my colleague, Don Lloyd-Jones about this. It's like, why do you think this is happening? We're doing everything the same way. what are we doing wrong? And we think that the men and women who we postponed their mortality, they were not dying as early, but they were still eventually dying from cardiovascular disease. So we need to do a better job of trying to tease that out, because we do eventually have to die, but we want to make sure that we are doing the right thing for our patients. So this doesn't always tell everything. So I just want to talk about what we have done in the Rush Heart Center for Women. I gathered a group of my colleagues. Dr. Gina Lundberg was my fellow at Rush many, many years ago, probably 30 years ago, but she is now the medical director at Emory. And we wanted to write why we started Heart Centers for Women. So we published this in Circulation, the historical perspective of formation and future strategies to reduce cardiovascular disease. And notice that we didn't say for women, because we think that by learning how to treat women, we are also going to learn how to treat men from cardiovascular mortality. So these are my colleagues. Some of you may recognize Dr. Merez, Dr. Sandy Lewis, Dr. Melissa Wood, Dr. Bob Harrington. And what we wanted to do was, a lot of people were asking me, why did you start a heart center for women? How do you do it? And so we wrote this paper. And as a matter of fact, we were asked by ACC to write a toolkit for how to start a heart center for women. And we just did that, and we have created a business plan. So anyone who wants to start a heart center for women, they have a template, and they have a business plan that they can present to their administrators for all the things that it would cost to start a heart center for women. And it's really not that hard, and it's not that expensive, because you have all the tools. It just takes one person to be passionate about making it work for women and creating the marketing for advertising to women so that they will come before they have their cardiovascular event, and taking care of the women who have had a cardiovascular event and making sure that you do very good secondary prevention. So this was our template for in Circulation about what we think we need to do to take care of women and also men. So patient care is, of course, has the utmost importance, and that's what we do at Rush. Patient care is the #1 thing at Rush, and we are very proud of that. We wanted to increase awareness, not just in patients, so patient education and academic education. So I go all over the world to teach about heart disease in women, because it is a little bit different than taking care of men. And then, of course, research is extremely important, and we continue to do that as well. This was my mentor's article that was just published in the Circulation Go Red for Women issue every February. The Circulation and the Circulation journals of the American Heart Association will always publish a Go Red issue in February to increase the publications of information about heart disease in women. And Dr. Nanette Wenger wrote this feminine face. She has been a pioneer since she became a cardiologist at Emory more than 50 years ago, that we should stop approaching cardiovascular disease in women, or diseases in women, with a bikini approach. So when we talk about diseases in women, it's usually about the breasts and the reproductive organs. So that's what her bikini approach is. But she now knows that in 2024, there's a lot of different kinds of heart disease that affect women in a different way than it affects men, including non-obstructive coronary artery disease, such as microvascular disease, SCAD, which is much, much more frequent in women than men, a 9-to-1 prevalence or 9-to-1 ratio. Hypertension affects women differently than men. Heart failure is different in women, and we have something called peripartum cardiomyopathy that never occurs in men. Atrial fibrillation affects women a little bit differently. They have a higher risk of stroke when given warfarin, but when DOACs were given to women with AFib, that was negated. The difference was negated. So very interesting that women respond differently to drugs. And of course, women have more strokes than men, and peripheral artery disease affects women differently, and cardio obstetrics is also an important part of the care of women with heart disease. And then cardio-oncology is a little bit different because there are so many women with breast cancer that are given drugs that can affect the heart. And so have been studying that. And I'm lucky that I have a cardio-oncologist at Rush who has been helping me understand that better. And Dr. Farr interviewed Dr. Wenger about what she thinks is happening in this field. And Dr. Wenger says that we have come a long way, but we still have a lot to do. We still don't understand why women have more HFpEF than HFrEF, and how to treat that in a better way. And until last year, we didn't really have good treatments for HFpEF. But hopefully we will do better. So Dr. Bello at Cedars-Sinai, she was at Columbia and moved to Cedars-Sinai, gave a proposal of how we can improve the care of women. We need to standardize inclusion of a reproductive history whenever you see a patient in the office. If you don't do that, you are missing an important part of their history to understand whether they're at risk for heart disease. So if you're not asking if they had any adverse pregnancy outcomes, such as preeclampsia, gestational diabetes, gestational hypertension, you might be missing that they have a slightly higher risk of cardiovascular disease, especially atherosclerosis. So that is a risk enhancer that is in the guidelines that you need to ask for. Also, thoughtful planning of how to include women. We need to increase a lot of cardiovascular trials, only include 30% women. And that may not be enough to really identify how women patients respond to drugs. And I'm actually part of a study right now that is an atrial fibrillation study. And I'm on the scientific advisory board of it. And people are complacent that we've enrolled 30% women. And I said, I'm not sure that that's really good enough. And their response was, well, it doesn't occur in women as much as in men. But if you don't study women equally, you will still miss the effects in women. And when you do the hazard ratio and adjust for sex, it still may not be good enough. So we really are trying to enroll more women in clinical trials, and they approach Centers for Women to include more women in these studies, because I think what we have been very successful with is including women in our studies. When I ask them to be in a study, they say yes without any hesitation because they trust me. If you don't have a good relationship with these women, they will not trust you, and they will not be, they are much more reluctant than men, I find, to be included in studies, especially antiarrhythmic drugs. That was a nightmare. When I would give antiarrhythmic drugs for atrial fibrillation, it was really hard to get women to try some of the drugs, especially when I said, well, there is a possible pro-arrhythmic effect and it can kill you. They said, oh, no, I'm not taking that. But the man's like, sure, I'll take it. It's like really hard to get the women. And we need to develop a diverse workforce. And I think we're all trying to do that. I'm so happy to see that you have so many women in your faculty and so many women in your fellowships program. So it's great to be here and feel so welcome. So I'm going to start my talk. That was my introduction. So what I'd like to go over is sex differences in patients with cardiovascular disease, review some of the guidelines, and then review some sex-specific diseases such as pregnancy and menopause and breast cancer that affect women and not men. So cardiovascular diseases everywhere. 1 out of 3 will have some form of cardiovascular disease, both men and women. We have similar risk factors, but we are affected a little bit differently, such as diabetes is a big risk factor, much worse risk factor for women than it is for men. So we really need to make sure that we are taking good care of those women with diabetes because they're not doing as well as the men. And then we're going to talk about the different sex-specific diseases. We wrote this paper that was published in JACC with my colleagues at the ACC for the ACC CVD in Women Committee. We wrote a lot of papers, as I told the fellows yesterday. I was mentored by Dr. Carl Pepin and Dr. Noelle Berry-Mers when I was in that committee, and they were just amazing mentors. So I was encouraging the fellows to join the ACC committees because that's where you get to meet people. And they are always inviting fellows to be part of those committees. So each committee at the ACC, and Eugene and Richard knows this very well, we welcome fellows in every committee. So make sure, Rose reminded me, in September, when ACC sent you that letter, would you like to nominate yourself for a committee? Say yes. Choose the committees that you want to be part of because it's a great opportunity for you to join. So, we wrote this as part of the committee in CVD and Women Committee, and we wanted to emphasize that young women aged 35 to 54 have not been treated as well as the older women and men. So we wanted to really discuss why women have worse outcomes when they have heart attacks at such a young age of 35 to 54. Nowadays, that sounds really young. And these women, if you have a pregnant woman with an MI, what is your first differential? What should be in your first differential? Anyone? SCAD. Perfect. And that's what I tell everyone. It's like, you got to think of SCAD because if you don't think of it before you go into the cath lab, you may miss it. So if there are any interventional cardiologists here and in Zoom, please take care of these women and look for that SCAD because that's most likely what the cause of that MI is in that young woman. But there are other causes. If it's not SCAD, it could be microvascular dysfunction, or it could be good old atherosclerotic disease in a high-risk young woman who have severe family history. And what I usually look for is lipoprotein A in these women, because if they have elevated lipoprotein A and they have a family history and their LDL is a little bit elevated, they could develop severe atherosclerosis at a young age. And so you have to think about those. And of course, embolus and thrombosis are also causes. So think about non-obstructive disease, think about spasm, think about SCAD in these young women. We were asked by this journal to give us our approach in managing ischemic heart disease in a heart center for women. So I asked my colleagues from all over the country to help me with this. And Dr. Abha Khandelwal was my fellow at Rush, and she's now at Stanford and helped with the Heart Center for Women. And she became very interested in this field as well. She wasn't really into it when she started with me, and she goes, oh, well, you know, there's really not that difference in men and women. And then by the time she realized what was going on, she goes, yeah, you're right. We need to do this. So she's become a believer. And Dr. Abha Khandelwal was the first author of this part of this article that we wrote. I actually asked other women from all over the country to help us with this because I know that they deal with this. So what we did with this paper is we divided acute and chronic and what you would do to manage or to evaluate ischemic heart disease. So you're going to do an angiogram and you're going to determine whether they have obstructive or non-obstructive heart disease. If they have obstructive heart disease, there are three possibilities. Do they have plain old atherosclerosis, which is everyone knows how to treat. And so that's why you're seeing this green, which is the level of evidence and how to treat atherosclerosis is the most known and highest level of evidence of how to treat these people with atherosclerosis. But the ones with the other diagnosis, such as SCAD and stress cardiomyopathy, look at the level of evidence, very little. So you're really trying to figure out how to treat these patients without a lot of guideline direction. So it's really hard to know how to treat these women. And that's why we have consensus statement papers that we've been writing about how to treat these women, because there's no guidelines. And to be in the guidelines, you almost always have to have randomized control studies. And you can't, it's hard to randomize patients with SCAD and stress cardiomyopathy because it's not that often, they're not that prevalent. And you can't randomize their treatments very easily. For non-obstructive, it's a little more complicated. Do you do coronary functional testing here? You do? Oh, wonderful. So we started doing coronary functional testing through PET, and then now we do invasive coronary artery functional testing. We've learned from our colleagues from Cedars-Sinai and other institutions how to do it. It used to be much more difficult, but now with the Abbott catheters, and people feel more comfortable with it. The more people do it, the better the outcomes are. The scary thing about it is you are inducing severe spasm in some of these women, and they could really clamp down and not open up with IV nitro, sublingual nitro. And it's very scary for that interventionalist to do that because you're inducing a potential MI. But as you see, again, level of evidence for the treatment of microvascular disease is not as good. We don't really have a lot of randomized control studies in this, but we should probably be doing that soon. And I know that Noelle Berry-Merce at Cedars-Sinai is heading a lot of those studies. For vasospasm, what we've learned is a lot of my patients, I was telling the fellows yesterday, I had one patient who had gone to the emergency room 30 times before she saw me. And when she when she had the coronary functional testing, she had severe coronary and epicardial coronary spasm. And she said, yeah, that's my chest pain. And so we were able to get rid of her beta blocker and gave her 2 calcium channel blockers to help with her chest pains. And she hasn't been to the emergency room in the last year. So I'm very proud to say that we were able to help that woman from not understanding her disease. And people didn't know what to tell her because they couldn't really tell her what her diagnosis was. So it was really helpful for that one patient, and I'm sure that you will see a lot of patients like that. And then myocardial bridge is another diagnosis that we see sometimes. 2 years later, Jack wrote this paper, published this paper, which I think was excellent. As you see, they also divided the different kinds of ischemic disease in women. And it shouldn't be just in women because there are plenty of men who also have microvascular disease, who have plenty of chest pains that we can't explain with a negative stress test. So they may, unless you do a PET, you will not be able to find whether they have microvascular disease. Some men can have this too, and they may need comprehensive coronary functional testing. This is a good paper. I know this is hard to read, but I just wanted to point out that they stated that existing centers focused on angino with no obstructive coronary arteries are usually done in women's heart centers because we were the ones interested in helping to understand what was causing chest pains that were hard to understand in women. But because it is also prevalent in men, everyone really needs to be doing this. And so for all the interventional cardiologists out there, if you're not getting enough procedures to do, this is a great way to increase your volume, and you could really help a lot of people understand what's causing their chest pains without obstructive coronary artery disease. So please do help these women and men. So these are some of the treatments. They don't really give a level of evidence, but these are some of the treatments, as you can see, for coronary microvascular dysfunction, spasm, whether it's microvascular or epicardial coronary spasm, and endothelial dysfunction. The first form of treatment is statin, exercise, and weight loss for all of them, except for the myocardial bridge. So those are your mainstays. You're going to treat them with statins, lower their LDL, stabilize the plaque. Exercise is a must for these patients. I've had so many women with severe angina. Sounds like angina. We couldn't get a positive stress test before we did coronary functional testing, before we had PET. Dr. Barry Mercer said, just make them exercise. And cardiac rehab was great for them. You can use stable angina as a reason to do cardiac rehab, which is accepted by insurance companies. And it really, really helps them, and emphasize that they have to exercise at least 5 days a week. And that has solved so many of my patients' angina. So I can't overemphasize the importance of exercise in treating these women, and weight loss. And with the advent of the GLP-1 agonist, I think that would really be interesting to see if it helps the chest pains of these women. So we'll see if the semaglutide and all the other diabetes medications can help these women. I'm really curious to see if using these drugs, which are much more helpful in cardiovascular disease, is going to equalize that mortality in women with diabetes compared to men with diabetes. So what are the sex differences in chest pains? When you have men complaining of chest pains, it's easy. It's usually obstructive coronary artery disease. You stent it. But for women, you can see there are many reasons. They could have SCAD, they could have microvascular dysfunction, they could have vasospasm. So it depends. Many reasons. You don't want to stent a SCAD unless they have total obstruction of flow. You try not to stent a SCAD patient, because what could end up happening is that dissection could propagate distally, and then you're going to end up stenting the whole artery. And that's happened to some of my patients. I'll see them after they have what we call full metal jacket, and they have stents everywhere because of SCAD. So try not to if you can. I know you had a long discussion about the chest pain guidelines that Martha Gulati chaired, so I'm not going to belabor this, but I just wanted to say that what I found the most helpful in assessing chest pains in people was this graph that they wrote. If they have low risk for coronary artery disease, they have no risk factors, you probably don't need to do cardiac testing. You might want to do a CAC score, because that can really help to decide whether they have coronary artery disease or not, or at least a calcification of coronary artery disease. And then if they're at intermediate high risk, it depends on the patient's age. And this is the best advice that I got from this chest pain guidelines. Younger patients should get the CT angiogram versus a stress test, because younger patients most likely have non-obstructive coronary artery disease, and you're going to miss it with a stress test. So that's what I've been doing, and it's been incredibly helpful because I've identified so many young people with atherosclerosis and a CT angiogram, which I would not have gotten that information if you do a stress test. So speaking of stress, I'm sure you have all seen stress cardiomyopathy in your patients. This is the typical apical ballooning that you see in Takotsubo cardiomyopathy or stress cardiomyopathy. We summarized in a paper the sex differences in Takotsubo. And most of the patients were postmenopausal women, 70 to 80%. They were usually exposed to severe stress, and in very rare cases, severe happiness. So it could be a happy heart syndrome, but it's usually a bad emotional or physical stress. They can look just like a heart attack, and fortunately, most do recover, but they can have recurrences. So we wrote this article to just show this different sex differences in Takotsubo. And what we found was that it's known that the prevalence ratio is 9 to 1, so it's much more common in women than in men. We don't know why that is, and it happens in mostly postmenopausal women. But when we looked at the triggers, it's interesting that in women, the emotional trigger was higher than in men, and in men, physical trigger was higher than the women. And it was found that the men had much higher mortality, probably because these men had severe underlying illness, or they were in cardiogenic shock compared to the women. So very interesting, higher mortality in men, but it's probably because they had severe physical illness. So these emotional outpouring of adrenaline causes this change in women that we can't understand. Hopefully we'll find some answers. I know that the Japanese are really looking into this, and they're really looking at genetics and biomarkers and looking at the molecular level to find out. It's a fascinating way that the heart responds to this, that it just balloons out and then it goes back to normal. It's just, how does that happen? And I'm sure some of you can, think about this and find out the answer why women tend to do that. So I gathered some of my colleagues at Rush, and it's like, let's talk about why women have so much microvascular disease. And I got together with some of my neurology friends and my rheumatology friends, and we noticed that there is a pattern that we're seeing in women, that they tend to have more autoimmune diseases, and their cardiac complications are usually based on microvascular disease. Pulmonary arterial hypertension is more common in women than men, and I'll show you the prevalence of these diseases compared to men. So the red are women and the blue are men. So Alzheimer's is predominantly in women. HFpEF is, if a woman is going to get heart failure, they're going to get HFpEF. That's usually due to HFpEF, which is turning out to be probably due to a microvascular disease. Migraines are much more common in women. We talked about pulmonary arterial hypertension. Autoimmune diseases such as rheumatoid arthritis and lupus are much, much more common in women. And Takotsubo is probably going to turn out to be also due to microvascular disease. Jordan told me he had to leave. It's not that he doesn't like what I'm saying, so just. So as I promised, I'm going to talk about diabetes and outcomes in women. As you can see from the slide, the hazard ratio is much higher. The relative risk for cardiovascular events and deaths and strokes in women are much worse than in men. So in terms of sex differences, the predisposition to occlusive vascular mortality, coronary heart disease, and strokes are this in men and this compared to women. So they have much worse outcomes. We really need to pay attention to our diabetic women because I don't think they're getting enough treatment. We need to make sure that their hemoglobin A1Cs are controlled. I have so many women whose hemoglobin A1C are 10. And, you know, I think it, and the endocrinologists are just not having a good enough outcomes with their drugs until all the new drugs are now around to help with that. And I think that the future is good to help these women. So heart failure is another interesting problem in women. So men get HFpEF just as much as women. It's just that women who have complaints of heart failure, you have to think of HFpEF as a cause of their shortness of breath, because they often have preserved ejection fraction. A lot of women who are having exertional dyspnea, high BNP, make sure that you assess them for HFpEF. I love this article that it's a consensus statement paper that Dr. Kittleson and, as you can see, Dr. Clyde Yancey was the last author. And they gave this algorithm that I think is extremely helpful to see if your patient has HFpEF. So it's this H2 HFpEF score. So if you have a woman or a man complaining of shortness of breath, and they have elevated BNP, and you suspect that they may have HFpEF, do this algorithm. If they have greater than or equal to 6 points, they most likely have HFpEF. And then you can be really aggressive in treating them with the right drugs. And these were, and as they pointed out that women have these different risk factors compared to men, such as preeclampsia and central obesity. Women have more symptoms. And there are some echo findings that are also different in women compared to men. So this is the treatment that we currently have. And as you can see, the only one that has a class 1 evidence is the loop diuretic agent. But I'm happy to see that there is, the first line of treatment is an SGLT2 inhibitor. And you may not recognize, so this is a class 2 indication, that's why it's in yellow. But there is a green outline that they point out that they believe that it's going to be in the next iteration of the guidelines for heart failure. So they really are very confident that there's a lot of promise with SGLT2 inhibitors helping with this problem. The one thing I wanted to point out is that there is a difference that they point out for patients. Women at all ejection fraction could benefit from MRAs, from mineralocorticoid antagonists, and also from ARNIs. Compared to men, they need an EF less than 60%. So for women, you can start using MRAs and ARNIs, but for the men, they really need to have a lower ejection fraction. So very interesting that they have these sex differences in their consensus statement. So we looked at the effect of atrial fibrillation in HFpEF, and we were really, this is my group of colleagues at Rush, and we really were surprised to see that HFpEF with atrial fibrillation has a much worse outcome than HFrEF with atrial fibrillation. We were really surprised. I did not expect to find this as one of our conclusions, but that seems to be the case. AF increases mortality in HFpEF, but not in HFrEF. So please pay attention to those patients. And remember that atrial fibrillation gets 2 points in that HF2PEF. So we really need to be very aggressive with these patients. There have been studies to show that atrial fibrillation in HFrEF has really, catheter ablation in those patients has really helped those patients decrease mortality, decrease hospitalizations, but not in HFpEF. We did so this is the usual ASCVD risk score, but for women, please remember that they have risk enhancers from adverse pregnancy outcomes and from early menopause. So we need to remember those other adverse pregnancy outcomes for these women. We wrote a paper. This was Dr. Cho and I shared this paper. We basically summarized the preventive guidelines to prevent heart disease in women. So we looked at hypertension and diabetes, and we looked at all the different problems that women needed to prevent so that they can lead better lives. And then hormone replacement therapy. What should we do with these patients? Well, we know that even if you give hormone replacement therapy to young women, it will not decrease their cardiovascular outcomes. That has been shown not to be the case. Hormone replacement therapy does not decrease cardiovascular disease. But if your young women are having menopausal symptoms, it is safe to give it to them for a limited time. So I would not hesitate to give my perimenopausal women who are less than 10 years from their initial menopause year some form of hormonal therapy if they really are very symptomatic. So the risks are about neutral for the benefits of hormone replacement therapy from cardiovascular disease. We also wrote this paper. Lakshmi Mehta has been very productive in doing a lot of papers also in well-being and in women and heart disease. And we partnered together a lot when we were at the AHA Women and Cardiovascular Disease Committee. So we talked about the differences, the different risk factors and the common risk factors in cardiovascular disease and breast cancer. We know that advanced age is a risk, diet is a risk for both breast cancer and cardiovascular disease. Being obese and overweight and alcohol intake increases breast cancer starting with 0, so that any alcohol can increase the risk of breast cancer in women, which I don't think women know that much. So, you know, a lot of women after they get their breast cancer are told that, but I think there's just not enough knowledge given to women to prevent cancer, to prevent breast cancer, that they really need to limit their alcohol. So I know we all drink a little bit, but we have to be conscientious about how much we drink because it does increase the risk of breast cancer and other cancers. Hormonal replacement therapy or hormonal therapies to prevent a secondary breast cancer is also very important to understand in women because the SERMs or the selective estrogen receptor modulators such as tamoxifen can increase pulmonary embolism and venous thromboembolism, but more importantly, for your patients who you're following who are on aromatase inhibitors, such as anastrozole or Arimidex, can increase cardiovascular outcomes. And a lot of these patients come to the Rush Heart Center for Women and they have high blood pressures or their lipids are gone up, and we need to treat them aggressively. So we don't necessarily tell them to stop their aromatase inhibitors, but I will be much more aggressive in these patients to treat their blood pressure, to treat their lipids, because they need it for those 5 years or however long they need it based on their oncologist's recommendation. But I will work with the oncologist to help these women. So very interesting. And this is just a summary of what Dr. Bello published in the Go Red for Women Circulation. And I know it's hard for you guys to read, but I wanted to emphasize that she talks about the differences in heart disease in women and men. And these are just some of the examples. And I know I don't have too much time, so I'm not going to belabor this, but she goes through all the differences between men and women and cardiovascular disease. So Catherine Otto emailed me that she couldn't be here, but she was pretty sure that there is a difference between men's hearts and women's hearts. So I hope I showed you that there is a lot of differences in heart disease in women and men. So thank you. I'm happy to answer questions if
Thank you. That was wonderful. I think we have time for 1 or 2 questions. Are there any questions in the audience here?
I have a question. What do you think was driving the differences in diabetic control among women? I hear, do you think it was a biologic difference, or anecdotally, I hear a lot of people like have such caregiver fatigue and burdens at home that they don't take care of themselves, and we depend on our. So, what do you think?
Thank you for asking that question. I was actually invited to the International Diabetes Federation to talk about, to discuss that. So I did a lot of research on this. And I was among endocrinologists. So I was, it was really a very interesting conference. So I learned a lot from them. I really looked into this. And what we decided was that women, what we found was that women were being diagnosed with diabetes a lot later than men. We may need to change the hemoglobin A1C cutoff for women because we're finding the diabetes in women much later than we are. They've already developed the cardiovascular disease that we are detecting earlier in men. So we're working, the endocrinologists got really fired up about this. So they're really trying to figure out whether we should be doing that in women. The obesity cutoff for metabolic syndrome may be different in the different races. As you know, they're already thinking that Asians should have a smaller range to diagnose metabolic syndrome, but we may also need to decrease the hemoglobin A1C cutoff to say, yeah, you're diabetic. Because right now it's the same for men and women, for all races, 6.4, you're diabetic. And you won't even get semaglutide approved to be given unless they have a hemoglobin of 6.4. So we really need to study this. So let's try to work with our endocrine colleagues to see if we can find that. So we need to do research on that. So thank you for asking that question. I hope it answers your question.
Thanks. Just a comment from the chat from John Blair that actually great point about the invasive evaluation, that we're actually doing that here
Right.
and that there's registry
Oh,
data.
wait, John Blair?
Yes.
Where is he now?
Here.
Oh, he's the one who taught us how to do it.
That's right.
John, thank you. Well, no, he was at University of Chicago, and when we started our program, we reached out to him and said, "How do we do this?" And so I didn't even know that.
Yeah, so he moved here.
Eugene, why don't you tell me? It's all your fault.
Yeah, let's blame Eugene for everything. So thank you. I think we're just at the end of our time. I really want to say thank you to Annabelle for visiting us and educating our fellows and for our great grand rounds today. As a reminder, we are taking a photo. So for the faculty that are here and interested, and for all the fellows, come over to Hognes and we'll take a picture on the steps. And you still have a couple sessions with the fellows to follow, but thank you for visiting us today.
Thank you for having me.
All right, thank you. I realize you knew John.